Hello everybody, my name is Dr. Desuter. I'm working at the USA in Antwerp, Belgium. This is a course aimed at helping residents and also SLPs of our department to deal with the dysphagia by screenplays, functional evaluation of swallowing. So basically, the examination of a dysphagic patient, dysphagia being a symptom, has to be well, the technical issues have to be preceded by a good evaluation of the medical history of the patient, a good anamnesis, questions that are well asked and oriented, and of course a good observation of your patient and even palpating the neck. This being done, we can skip over to the next point, which is the video endoscopy. The video endoscopy will be divided in three moments called point of interest, PI1, PI2, and PI3, with the scope stopping first at the level of the cohana, secondly in the laryngeal introitus of vestibulum, and we will then pull it a little bit up to have a global picture of the pharyngeal larynx. So the fees moment will be divided itself into several challenges. We will ask the patient at point of interest number 1, we will ask him to say ok to evaluate the soft palate mobility. At a point of interest number 2, we will ask the patient to say e to evaluate the mobility of the glottis. And then, and only then, we will start with challenging the patient with a bolus. We are using liquid bolus as a start, which is tainted by methylene blue. The first challenge is quite easy. You give a sip to your patient between 5 ml and 10 ml, preferably 5 ml, and you ask him to keep the bolus in the mouth. Challenge 2 is asking the patient to swallow the bolus that he has kept in his mouth. Challenge 3 is reloading the patient with a new sip and ask him to swallow it immediately. Challenge 4, it's whatever you want. You can test the sensibility of your pharynx and larynx. You can also saturate your patient with asking him to swallow several sips in a row. You can also challenge different scenarios that you suspected before. And after doing that, post endoscopic examination, you should be able to code the fibroscopy of your patient. So if I remind you, this is the first point of interest. Well, the scope will stop at the palatal mole here and look at the coana, and you will evaluate the mobility of the soft palate. At point of interest number 2, the patient will have a natural tendency to extend the head and pull the head backwards. That will help you to look into the laryngeal vestibulum and evaluate the glottis mobility. And finally, at challenge 3, which is at point of interest number 3, you will start the blue tainted challenges by pulling your endoscope a little bit more backward and having a big picture of the pharynx and the larynx, and then and only then, having that view, you will start to challenge the patient with bolus. Scenario 1 is an easy one because basically it's a normal swallow. While the normal swallow will be characterized by several features. At point of interest number 1, you will have a complete normal elevation of the soft palate, which is completely mobile and not presenting any bizarre or pathological motion like spasmodic contractions or the innervation contractions. At point of interest number 2, you will have a perfectly symmetric and mobile glottis with both vocal folds moving perfectly well with symmetric piriform sinuses. At point of interest number 3, you will start the challenge with the methylene blue. Of course, you will see any residue within the pharynx, what we call the 4 quadrants of the pharyngeal larynx, which is basically the 2 valleculae here and the 2 piriform sinus here. When the patient will be asked to swallow the methylene blue, you will see the methylene blue coming, and then you will have a big white flash on your endoscope, which signifies the contact between the endoscope and the soft palate. You will see anything, in fact, but just after that, you will have a cleared, completely cleared pharynx, no penetration, no sign of stasis during the swallowing. And then at point of interest number 3, you will repeat that sequentially, and you will notice exactly the same sequence with absolutely no stasis at the end. And at point of interest number 4, you will repeat several times the same swallowing to make sure that you're not missing anything. And this is basically the definition of a normal swallow. So here we will see some examples of normal swallow, exactly what I said. This is point of interest number 1. So you will be in the rhinopharynx here, and you will see a completely mobile soft palate, which is occluding completely the rhinopharynx, allowing to create a good bolus propulsion and a good bolus pressure in the oropharynx. At point of interest number 2, you will assess the mobility. So we are going to the point of interest number 2. You will assess the mobility of both vocal fold and the symmetry of both piriform sinuses. So this is done here. We in this case, we did a small stroboscopy within the same examination. No, perfectly all right. So we can move on, pull out a little bit the endoscope higher in the oropharynx, and then you will have a nice view of the entire pharyngeal larynx. This is challenge number 2. So you will ask your patient to swallow the bolus, and you will see absolutely a perfect clearance with no stasis present. And then point of interest number 3, challenge 3, and challenge 4 will confirm a perfectly normal swallow with a perfect pharyngeal clearance and no aspiration penetration, of course. You can repeat it several times during the challenge 4, or assessing the sensibility if you want by touching the epiglottis and the oropharynx, which we are doing here, which is perfectly correct with a normal coughing reaction. Let's go now to the scenario number 2, which is a completely descriptional and observational scenario. In fact, what we did was to create a little grid here with some components of the swallow, which goes from high morbidity to low morbidity here, and also classifying all these features by their frequency, very frequent, moderately frequent, and rare. And then this is based on our own experience. We will classify several features that are influencing airway protection during swallowing. One of the 2 biggest factors that influence the safety of the swallow for us consists in the lack of laryngeal ascension or elevation. You can assess that clinically also by palpating the neck and asking your patient to swallowing at the same time. And also the glottic insufficiency, characterized most of the time by vocal fold paralysis, which are the 2 main protection deficits of the airway, with the highest morbidity and also seen relatively frequently. Going to the next little classification here, you will see people with poor dental status, which is a scenario 2C. A lack of pharyngeal dynamic chamber, which is in fact a lack of elasticity of the pharyngeal wall, which are really important. These are classified 2D. And then you have xerostomy, mostly induced by medication, which is classified 2E. And then we're going, to features with a lower frequency but high morbidity, which is the lack of lingual propelling, mostly seen with people having trouble propulsing with their lingual base of tongue. These people can also be assessed by the IOP, assessing the lingual pressure they have. But also tracheostomy, as you can imagine, tracheostomy protects the airway, but on the other hand, pinpoint the larynx elevation. So 2G and 2A goes mostly together. We also know that once one arytenoid is missing, that it constitutes a lack of protection of the airways during swallowing. Also, the absence of epiglottis, moderately frequent, especially with head and neck cancer patient, but with a low mobility. As long as you have a good PECSI, the epiglottis is not as such completely necessary. And then you have also the lingual defect, which is an anatomical defect, or the two arytenoids that are missing. These are really high morbidity features, but are relatively rarely seen. Then you have also anatomical procedence in the pharyngeal lumen. You can have an external carotid artery, which is procedent, but you can also have hyoid bones that are procedent. And then you have velar deficiency. The velar deficiency is mostly evaluated during the point of interest number 1, whereas the deficit or mobility of the glottic plane or the presence or absence of arytenoid cartilages are mostly assessed during the point of interest number 2. And finally, it's sometimes difficult to make the distinction between a problem of D and a problem of F. That means a lack of pharyngeal chamber and a lack of lingual propelling. Basically, when you have a D, a lack of dynamic chamber, you're able to you have some residue in the valleculaires, but you're able to clear it completely. Whereas when you have a lack of lingual propelling, mostly after the pharyngeal swallow, after the white flash, you will have a little bit of residue coming down there. That means you will have a little bit of blue hanging there in the valleculaires. A few words again on the screenplay number 2. You can have more than one protective deficit. You can have several scenarios too, and you have to code them with the little letters. It's mostly observational. You can even suspect them without performing the endoscopy, like the laryngeal elevation, for instance, or the base of tongue comportment that can be also assessed more efficiently with the IOP, for instance. But they are very important hints for the speech therapies. They have to know if the arytenoid is missing. They have to know if the PECSI has been done. They have to know about laryngeal elevation. So these are really features important to note for the SLPs you're going to refer the patient to. And of course, these features can be observed during many stages of the video endoscopy at point of interest number 1, 2, 3, and at different challenges. So these are different examples of protective deficiency. This is a screenplay 2B with a glottal gap. So that's we're still at the point of interest number 1 here. Then we're going to go to the point of interest number 2. And what we're going to immediately see is a vocal fold paralysis here on the right with a complete dilatation with some residue of the right piriform sinus. And this is also, of course, pathognomonic of a vagus nerve injury. This is a 2M. You see here that there is a lack of closure of the soft palate visible at point of interest number 1 with evidence of a nasal reflux during the pharyngeal swallow. This is a 2L, pharyngeal procedence, seen at point of interest number 2. Here you're going to see something, hanging up here in the blocking the access to the right piriform sinus, and this is the hyoid bone here that is proceeding in that lumen. This is something interesting for the speech therapy, and she or he cannot see that with our clinical examination. So this has to be noted in the file. So after seeing scenario 1, which is normal, and scenario 2, which are the description of some protective issues, we're going to switch to the scenario 3, which is in fact, it can be defined as an oral incontinence. So put you in the setting of a point of interest number 3. You're up there looking at the pharyngeal larynx, and then challenge 1, you ask the patient to have a sip of blue and keep it in the mouth. And the problem is that the patient is not able to keep it in the mouth. And you will see here a relapse of blue in the left vallecula here. And then afterwards, of course, at challenge 2, the patient is completely able to swallow correctly with a normal clearance and no stasis. So the fact that the patient is not able to keep the bolus in his mouth during the challenge 1, this is the definition of the scenario 3. This is quite evident to see. I'm going to see an example of that. So this is an example of the scenario 3, known also as the oral incontinence. Point of interest number 3, challenge 1. That's where we see it. So you basically ask the patient to have a sip and keep it in the mouth. Here we are at point of interest number 2. And then we're going to start challenge 1. So we basically give a sip of blue dye to the patient and we ask him to keep it in the mouth. Will he or she be able to do that? We're going to see that immediately. So still checking the mobility of the glottis here. Then we have to keep it in the mouth, and no, there is some blue relapse here. Not enough to trigger the pharyngeal swallow, but still the posterior oral incontinence is not perfect. But the pharyngeal swallow is okay. You have a perfect clearance and no stasis at the end of the swallow. So it's a pure scenario 3, posterior oral incontinence. So screenplay number 3 or scenario 3 is mostly a reflection of an oral issue that can be of different origin, lingual dyspraxia. It can also coexist with facial palsy, but also with a lack of volume of the tongue, a lack of innervation of the tongue, or a ninth nerve paralysis. Several options are still possible here. Okay, let's move on to scenario number 4, which is the delayed pharyngeal reflex. The delayed pharyngeal reflex can be of two kinds. The first one is of sensitive origin, and the second one is of motor origin, 4A, 4B. Basically, what you have here is a delayed pharyngeal reflex. So that means that you are at point of interest number 3, challenge 2. Your patient is loaded with the blue dye, and then you are going to ask him to swallow. He's going to execute the order. He's going to swallow. The problem is that the blue will go very, very far down, up to the bottom of the piriform sinuses, even over the arytenoid cartilage sometimes, before triggering the pharyngeal reflex and the white flash on your scope. But on the other hand, the clearance will be perfect, and you will see no stasis at the end of the swallow. The type A, it's mostly one-sided, that's one, and then it's basically due to a lack of sensitivity that you can also assess during the challenge number 4. Tickling with the tip of your fiber, the epiglottis and the oropharynx, to see if there is a lack of sensitivity and compare both sides. The type B, on the other hand, it's more it's related to rigidity most of the time of the contractors and also on the base of tongue. It's mostly seen with motion disorders like Parkinson's diseases or post-radiotherapy patients. So there is a lack of motoric response, the sensitivity being okay, but the brainstem sends the normal order to the muscles, but the muscles being rigid are a little bit delayed in their action, and then you will have the same image, in fact, but with no sensitivity problem here. So these are examples of scenario 4, also known as delayed pharyngeal swallow. This is a 4A with a sensitive issue. We are here at the point of interest number 3, challenge 2, and you're going to ask your patient to swallow. And it's not happening here, but here it's really clear that you do have blue going up to the bottom of your piriform sinus without triggering a pharyngeal reflex here. So there is probably, and you see here exactly the same feature repeating, there is probably here sensitive issues, and then you will confirm that by teasing a little bit the epiglottis and the oropharynx, and you will not trigger any reaction of your patient. This is a 4B. Also a delayed pharyngeal swallow, but mostly caused by muscular and motor deficits. Here you can see here a patient that has had a brainstem CVA recovering, but you see clearly that there are still a deficit in timing of the pharyngeal phase. So there is a delay in pharyngeal phase. Here you have another 4B. Sometimes it can be dramatic with some aspiration and penetration. I think it's going to be the case here. You will see that the blue is massively getting even behind on both sides, behind the arachnoid cartilage, and it's almost a miracle that the patient doesn't cough here. But finally, he's gonna cough and he's gonna aspirate. Anyway, this is it for scenario 4. Let's go now to the scenario 5, which is in fact stands for the oral dyspraxia. So you're at point of interest number 3, challenge 1. Everything looks okay, and then you give the order to swallow, going from challenge 1 to challenge 2. And the problem is that giving your order, the patient will have several retropulsion motion of the base of your tongue, but that are not effective, that are not producing into a true pharyngeal swallow. So you're going to have several aborted motion of the base of tongue before having one effective. And once you have one effective, it's completely effective, and that's translated into a white flash, a classic white flash with a perfect clearance with no stasis at all. Let's see that on a real patient. So screenplay number 5, lingual dyspraxia. You're going to see here examples of patient. We are at point of interest number 3. We are looking at the pharyngeal larynx. Challenge 1 has been done, and now you're asking the patient to swallow. So you're shifting from challenge 1 to challenge 2. And what we're going to see is the following feeder. Point of interest number 3, challenge 2. We ask him to swallow, and that's what we're going to have. You know, a kind of aborted motion, hesitation. Some are speaking about dancing base of tongue here, before having a true pharyngeal swallow. And the pharyngeal swallow is okay. You see here, there's a little bit of stasis in the valleculae. Okay, and you can repeat that. It's inconsistent. Sometimes it happens very strongly. Here you see 1, 2, 3, 4, 5, almost 5 aborted motion of the base of tongue before having one which is effective. So you can test that again during the challenge 4 if you're not sure. You ask the patient again to keep it in the mouth, and then you see here that the base of tongue dancing with aborted motion before having before being followed by an effective pharyngeal swallow. Here you see the same. You see this aborted motion here. This is clearly a lingual dyspraxia. So if you're not sure at challenge 2, you can repeat exactly the same challenge during challenge 4 and check if your first ID was right. Let's move now towards scenario 6, which is the scenario translating propulsive disorder, which is a very frequent disorder, especially for neuromuscular disease patients. What you're going to have here at point of interest number 1, you might have two options, whether a normal motion of the soft palate or an incomplete motion of the soft palate, which happens from time to time, especially in neuromuscular patients. So that you're going to code 2M because it's also a protective issue. At point of interest number 2, what you're going to see very frequently, especially in myotonic dystrophy patient, you're going to see residue. So you're going to see whether saliva or food that is hanging there, whether only in the piriform sinuses or only in the vallecula or both. So this is really typical of a neuromuscular disease. At point of interest number 2, you will see some residue. So you didn't even started with your blue dye test, and you will find out residue, whether saliva or food. At point of interest number 3, you're gonna have a challenge 1. So you give a sip to your patient, he keeps it in his mouth, and you don't see anything happen. The residue is still there. There is no escape of blue there. And then at challenge 2, the patient will swallow. Here it's wrong, the color should be blue. It will swallow the blue dye. You will have your flash, but the patient, and this is crucial, the patient will never be able to clear completely the pharynx, and you will have some stasis here mixing itself with the previous residue, and from one swallow to another, the residue will be replaced by the blue dye, but the patient will be never ever able to clear completely the pharynx. And this is a big difference with scenario 7, the resistive issue. And again, from time to time, you're going to see some food or some blue going into the rhinopharynx if they have a soft palate insufficiency. So this is typical of scenario 6. Two features that are typical. When you look at point of interest number 2, you will see some residue, and at different challenges of point of interest number 3, the patient will be never ever able to clear completely the pharyngolarynx. Let's see that in video now. Scenario 6, screenplay 6, also known as propulsive issue. Point of interest number 2. You see here that the patient is full of residue, so you haven't even started with the blue, and you see a lot of saliva everywhere, even if in the laryngeal vestibule. And then you're gonna combine challenge 2 and 3. You see that the 4 quadrants are involved in this residue. The patient is swallowing now, and the saliva will be replaced by the blue, but the blue will never ever be cleared completely, and you will never have a clear pharynx, which is really key. This is another example, which is with a massive penetration here. You see the patient is unable to clear the pharynx, and blue will go everywhere, even including in the laryngeal vestibule, causing some cough. Exactly the same here. You see some saliva residue here, mainly in the peripheral sinuses. Again, the blue is used, and the patient will be never able to clear it completely. The only thing you're going to get is a colored saliva and a residue that will be replaced by the blue you just challenged the patient with. To illustrate this scenario 6, also known as propulsive issues, we did a little study comparing 3 different types of patients. One was a control group, completely normal. One was a group of patients that were presenting myotrophic dystrophy disease, which is a massive propulsive disease. And then the third group here are patients presenting at the radiology what we call a CP bar, a cricopharyngeal bar, so some resistance to flow by the unrelaxing UES, upper esophageal sphincter, but still getting a complete pharyngeal clearance. That means that they could cope with it, and despite the higher resistance to flow, they could cope with it and clear completely their pharynx. And if you would put what we did was putting some manometric sensors in these 3 categories of patient and see what happened. And if you see that the cohort group had a pressure within the hypopharynx, which was more or less at 150 millimeters of mercury, of course, the people having a myotonic dystrophy were presenting a lack of propulsion with a completely dropped gradient in terms of millimeter of mercury. And at the contrary, the people that were presenting a resistive issue, that means a non-relaxing UES, had to increase their propulsion force to get through the obstacle, to get through the hurdle, and get a cleared pharynx. So there is a yin and a yang here between the resistive issues and the propulsive issue. You might have some resistance. If you have a good propulsion response, you can cope with it. If you have a resistance and you do not have any reserve of propulsion force, then you might be in trouble. Okay, and again, likewise, if you do have some propulsive issue, even if the resistance is low, you will have a patient that is not able to clear completely his pharynx. So there is a yin and a yang a kind of relations between the resistance to flow and the propulsion acting on that flow. And this leads us to the seventh scenario, which is in fact the resistive disorder. So we saw that we had some patient having a scenario 6, having some propulsion issue. But here, there is also people presenting a resistive issue, so resistance to flow, without any propulsion disease. And what characterizes these patients is at point of interest number 3, challenge 1 happens okay, with no problem at all. But what you can see from time to time is a little bit of residue on the midline, which is kind of characteristic for these people. So you have a little bit of residue there. Normally you should have residue in the piriform sinus or the vallecula, but not on the midline. That's very rare. At challenge 2, the blue comes, and this is the main difference with the propulsive patient. You will have a complete clearance of your pharyngeal larynx. So they will be able to overcome the higher resistance they have here. The higher resistance is mostly done to an unrelaxed UES, and this unrelaxation of the UES is mostly the consequences of lower esophageal diseases, most of the time. Sometimes also post-CVA with the discoordination into the neural orders and neurotransmitters, but it always comes down to the a dysfunction of the UES. And what you see here at challenge 2, if the patient is completely able to clear his pharynx, what happens afterwards, if you expect a couple of seconds, and please keep your scope in there, then you will see two possible things that happen. Whereas the reflux of some of the blue the patient were able to drink, or in some circumstances you can have also a gas reflux, which is an eructation. Boerke in het Nederlands. These are signs of resistance there. So there is something on the UES that is not normal. Even if you can't see the UES, you can infer this information quite precisely. The most known disease that has this feature, that presents this feature, is the Zenker disease. So the patient is able to clear his pharynx, but then after a while there is some regurgitation, and this is of course also a disease of the UES. So let's see some examples of that. The screenplay number 7, the resistive issue. Point of interest number 3, challenge 3 and 4. So you're going to ask your patient here, there is no residue on the midline, but you're going to ask your patient to swallow. And what you're going to see here is from time to time, if you saturate your patient by making swallow several times in the same bolus, you're going to see, here, you're going to see some bubbles coming up from down to up. And he's going to present some liquid refluxing with some bubbles coming here. You see these bubbles here? It's going to be more, of course, to be able to put that in evidence. You can see also that the patient has some trouble to clear completely the pharynx, but happened. And here you see the bubbles coming from down. Here you see clearly the bubbles that are coming from the esophagus and coming back here. So it's sometimes really, really difficult to see here. You see it clearly that there is some regurgitation. And if you wait enough, here the clearance is complete and you see the blue coming back here. So to really assess this resistive issue, please saturate your patient, make him swallow several times. This is an example of where you had this saliva residue on the midline. So you have it. You see that clearly. This is the sign of a UES dysfunction. Despite the fact that the patient is able to swallow it and clear it, it will come back and come back and come back. You see it here. This is not per se a Zenker dividiculum, but it might be one. But it could be a simple hyperrelaxation of discoordination of the UES. It is a resistive scenario. It is a scenario 7. To summarize, to have a efficient swallowing, what you need to have is a good propulsion force, a low resistance to flow, and good airway protection. If you have these three factors, you can conclude that your patient is safely and efficiently swallowing. So how do you transmit, with language do you transmit your conclusions here? It's quite easy. You have noted several scenarios because several scenarios can coexist indeed. So you will note it from the biggest to the lowest, all these scenarios, and then you will try to ponder them. You will try to weight them. So if you think that the scenario 6 is the main problem for this patient, you will write down that it corresponds to 80% of the problem. The 4B represents only 10% of the problem, and the 2A 10% of the problem. So you have to note by coding your patient the screenplays they show. You will weight them, and then you can add, if you're clever enough or if you're trained enough, you can add some indication of on the origin of the scenarios, a 4B and a 2A, for instance. So by coding the patient that way, you will use a language that should be understood by all the stakeholders, and that will be really helpful for your patient management. So this being said, this is the end of the course. I would like to acknowledge Mrs. Ann Johnson for her original drawings, which were fantastic. And if you want some more information, the global aspect of oropharyngeal dysphagia and the entire screenplay theory, you can find that out in a book published by Springer, in 2019. I thank you for your attention, and I hope this will be helpful to your clinical practice.